of Miami. Oops, there we go. Jillian Narcisse is a clinical pharmacist at the University of Miami Miller School of Medicine. Jillian, you're on.
And Jillian, your mic is still muted.
Okay, sorry. Good afternoon, everybody. Thank you so much for joining. So I'm going to share some updates about our clinic since we started the PrEP injections. So we started PrEP at our clinic since September 2018, and we've had a total of 1,924 PrEP starts. That's the oral and the injectable. And our first patient that we saw was in April 2022. And since then, we've had 25 patients on the injectable. And our first patient will be receiving their 8th injection next month in the first week. And that'll be about 1 year into the injection. And then our last one just received their first one this week on Monday. So we have 20 patients, 20 Hispanic Latinx patients, 3 African-American, 2 Caucasian, 2 transgender female, 2 female, and 21 male patients. So our clinic is unique in that we do not bill any insurance as to be seen for PrEP, but we do bill for the medication. And that's kind of like so I want to open that insurance flip-flopping. So our patients come in and out of insurance like all the time, like 3 times a year sometimes. So before January 2023, we had 21 patients on the injectable. 9 were uninsured and 12 were insured. And after January 1st, we had 25 patients, 17 which are insured and 8 are uninsured. And so the uninsured number went down a little bit. So we deliver using a hybrid model. So we have a mobile clinic. We go to different sites in the community to provide PrEP. So we do deliver, we do the injectable in our mobile clinic, as well as our static clinic. We use a clinical step approach as of January 2023, where we start Truvada, Descovy, Apretude, or if it's a female, Truvada, Apretude. So we do a risk factor-based and failed therapies. And if we use the adherence as a reason for Apretude, then we'll do 3 adherence counseling attempts, as we have seen some insurance pushback for that. And we use pharmacies to fill our Apretude and to be our clinic. We are seeing some trends that insurances prefer to buy and bill. So we are trying to implement that in our clinic, so to allow for equity in our clinic for all of our patients. So it's just me in the clinic. I am the person who focuses on this, on Apretude as well as Cabenuva. I use a tracker, a spreadsheet to track all my patients. I use a 28-day window and 56-day window because of February. It has 28 days to keep it across the board uniform for all my patients. And I do have a nurse on staff, 4 ARCH coordinators and 4 APRNs that help me with all of our patients. Our retention protocol, so how we approach that is to retain our patients. We have an initiation agreement that they sign before they even start the injectable, to ensure that they understand the commitment that goes with that medication. We do text message reminders. And if there are any missed visits, we do oral bridging. And all that is able to be done with our team collaboration between me, the nurse, and the ARCH coordinators. We've had to revise our protocol, our criteria protocol, just to check, they stay on it, because we all, next slides will explain what I mean. So we have a pre-assessment of oral PrEP retention, because that indicates how well they will be on the injectable as well, and also a step therapy approach. So as of now, we had one missed injection, and that one we're able to bridge with oral therapy. So it wasn't like a really miss, but like we were able to continue them on the injectable. And we've had 7 discontinuations. So 4 returned to oral PrEP, 2 were insurance denials, which is why we use the clinical step approach for that medication, because the insurance didn't saw that they didn't try the oral medications. They wanted to see side effects, adherence, technique, counseling. So that's why it was denied. And 2 voluntarily stopped the injection. So now they're back to oral. 1 patient moved to another state, and only wanted the injectable, and the insurance wanted to see that they had tried the oral medication. So it was denied. And 1 is a possible restart. I don't know if you are aware, but now ViiV switched vendors for their to start patients. So it was like around that time. So we're trying to restart that patient once I get the results from ViiV about their insurance. As far as access challenges, so that goes back to my insurance flip-flopping that I was explaining at the beginning. So we had a patient that went from insured to uninsured. And I only found out 1 week before they were supposed to miss the window. So I had to really, my FRM and my ViiV case manager really supported me to get this expedited, to get them the injection by the window. So that's a success story of almost missing, but we're able to get them that ASAP. And we had one patient that went from uninsured to being insured. I had a 1 month window between when I discovered they had the insurance, and we had to do the benefits verification and the prioritization. However, their insurance is particular in that they do it's called the CVS drug replacement program. And you have to enroll in that program, and only a medical doctor can enroll and prescribe. And we have APRNs. The pharmacy was not aware of this program and had to do mini calls and escalations. And I was able to get them the injection by the end of the window. So that kind of worked out for me, for him. So we had to revise, our retention protocol with the agreement and also the stepwise approach. And also adherence counseling is a really big thing with insurances now. What have you tried to get them to take the oral medication? So that's one thing that we're trying to reinforce with our patients before they can start on the injectable. And then we are trying to also implement buy and bill in our clinic. So that completes my slides. Thank you so much for listening. And next person.
Great. Thanks so much, Jillian. I'm sure that there are a lot of questions. I know that I have a couple. Again, please put your questions for Jillian in the chat, and we'll answer them as we go along. Just in the interest of time, I want to move on for now. So Caroline, it's your turn. Caroline Sacco is a clinical PrEP nurse at the Sexual Health Clinics Division of the Baltimore City Health Department.
Thanks, Robert. I'm going to share my screen. Can everyone see my screen?
Perfect.
Okay. So a snapshot of our injectable PrEP history. We gave our first injection back in April of 2022. In total, we have about 330 patients on PrEP, give or take. And that's like established patients who have received at least one prescription. We have 19 patients that have received at least one injection of PrEP as of April 2023. Some positive things I've noticed about who's starting injectable PrEP, we have more genders represented. So we have one cis woman, two non-binary people, and one trans woman, and or I'm sorry, two trans women, and that is I think proportionally more than we have on oral PrEP, than who we have on oral PrEP. Racially, I put the distribution there, some demographics down below, and we have about an even mix of uninsured, state insurance, what we call Medicaid, and then private insurance. So our PrEP team looks like 2 full-time nurses, 2 PrEP navigators, and 4 part-time providers. And I say part-time there because they actually are part of they take care of STI patients or HIV, people living with HIV or tuberculosis or Hep C. So they divide their time with different clients. And then in terms of retention efforts, we tend to select people, at least we have up until now, we've selected patients that have a high interest in injectable PrEP. Rolling out injectable PrEP for us went along with rolling out a survey, a satisfaction survey, where we did a little bit of education in the survey about injectable PrEP. And so what happened was a lot of people who completed the survey followed up with us to say that they were interested in injectable PrEP. And those were the people who were highly committed. And so sort of learned about injectable PrEP, like procuring injectable PrEP into the clinic alongside us. Another retention effort that we have is that we do personalized phone call reminders, and we give reminder cards at every visit. So typically our PrEP navigator is responsible for reminder calls, but with injectable PrEP so far, since missing an appointment can have sort of like quasi-clinical implications in terms of restarting, then for now, the nurse is the person who actually does these reminder calls. And then in terms of people staying in the program or staying on injectable PrEP, we've had one person who just completely changed their mind. And then we've had one person who had to restart because of missed appointments. And so his case is sort of outlined below. He wanted to start as a on-demand PrEP patient, but later at his follow-up visit 6 months after we started him on demand, he was diagnosed with gonorrhea and had a genital lesion. And so we kind of restarted a conversation about a daily or ongoing long-acting option for PrEP. And he said that he would not like to be on a pill, but he would like to be on a long-acting injectable. And so he completed Cabalon initiation by October of 2022. He was lost to follow-up between October and March of 2023, and he was actually hospitalized with COVID, but he's since restarted. So overall, I've been really pleased with our retention efforts. And again, I think it really has to do with that first bullet in terms of selecting patients with high interest. I don't think that, that might be at odds with what we're talking about next with this, which is equity efforts. But like I mentioned before, we have seen more people with more diverse gender identities want to be on injectable PrEP. And so that's really exciting. I have noticed that if the name on the insurance card is different, it can present like a significant barrier to starting injectable PrEP. And then this came up as something that we need to talk about as a clinic in general, sort of having more trans-friendly patient or visit flows and like procedures. And so we really need to be upfront at our clinic with patients about which name you need and why. And so this is something that I kind of want to pilot in light of the fact that we might be attracting patients who maybe wouldn't have come before, but now we're actually offering something that they're interested in. Also, another equity effort that we're doing is we want to start a community advisory body to help us establish sort of the goals of injectable PrEP and like how the program should work. This is something that would be new for the PrEP program, having like a direct community advisory body or board. So I think that rolling it out in conjunction with injectable PrEP would be a really powerful moment to do that. And then the third thing that we do in terms of equity is we track and monitor and evaluate PrEP education that's done from clinicians to PrEP clients or potential PrEP clients. So like if somebody comes in and would be a good fit for PrEP or mentions that they're interested in PrEP, or maybe doesn't, is kind of doesn't see their vulnerabilities, we want to know if the clinician is having the conversations at that time that they really should be having. And we want to know that they're doing it across the board, regardless of who the patient is. And so along with that, we track initiations, and we're doing more and more to track retention to see sort of how does our program do with keeping people in care. I looked at some data point today and just saw that cis women are more likely in our program to fall off from PrEP in the first 90 days than any other population group. So Black cis women. So that was kind of interesting. But that's where I'll stop for now, and happy to have the conversation later.
Great. Thanks so much, Caroline. Up next is Dr. Joseph Cheruby. Dr. Cheruby is Associate Medical Director at the St. Louis County Sexual Health Clinic.
All right, can everyone see and hear me okay? Do we have a thumbs up?
Perfect.
All right, perfect, thank you. So thank you so much for having me here today. So I'm gonna talk today, actually, while I am the Associate Medical Director of the St. Louis County Sexual Health Clinic, I'm gonna focus more on my role as the Medical Director for the Washington University in St. Louis PrEP Clinic, because that's where we've rolled out long-acting injectable PrEP. We have yet to be able to roll it out in the Sexual Health Clinic in St. Louis County. We've been focusing more of our efforts on oral PrEP and getting PrEP starter packs, same-day PrEP, and we have a collaborative practice with our WashU PrEP Clinic. But our WashU PrEP Clinic is uniquely situated in order to be able to provide long-acting injectable PrEP, and so we'll talk a little bit more about that clinic. And so this, the WashU PrEP Clinic is located in St. Louis City. It was launched in 2013. It is an academic medical center, and it is the largest PrEP provider in the region with a catchment area of rural Missouri as well as Southern Illinois. It is a predominantly urban setting, and we offer both in-person and telehealth visits. For every PrEP clinic visit, we have it is a referral infectious diseases specialty clinic. So I do want to highlight that does create a little bit of issues in terms of if individuals are insured or not, especially for long-acting injectable PrEP. But we try our best. And like I said, we do have a collaboration with our local health department in order to make sure that any individual who wants long-acting injectable PrEP can be referred to our clinic, regardless of insurance status, and how we can make sure that they get their labs and medications with minimal to no cost. Every patient is seen by an MD or an APP. We have 10 health care providers within our clinic who are capable of prescribing PrEP. We do have a PrEP navigator and coordinator, and they meet with every initial office visit, but also for any patient that has continued needs. And this will come up later when we're discussing especially what we do with respect to long-acting injectable PrEP and retention. On PrEP initiation, we do provide shared decision-making. And the reason why we do that, and I want to highlight that, is because on each initial office visit, we go through every single option with respect to PrEP. We want every patient to be well informed about what options are available, whether it's oral Truvada, oral Descovy, on-demand PrEP, or long-acting injectable PrEP. And whatever their healthcare goals are, we try to make that happen for them, with the understanding that some people will not be able to be started on long-acting injectable right away, and with the understanding that there are limited options for cisgender women, especially in transgender men. But we want to make sure that everybody is well informed and allow for any individual to be informed of what is required for any formulation of PrEP, whether it be office visits, whether it be injections, and to know what goes into those within each PrEP modality, what the clinical care looks like. We do have an in-house 340B pharmacy that fills the same day if it's oral PrEP, as well as they are the ones who provide our long-acting injectable PrEP. So our long-acting injectable PrEP is actually housed in our in-house pharmacy, and they are the ones who provide the injection. Through, they do have an MA on staff that is the one who provides those injections. And so it's a very close collaborative relationship. They happen to be upstairs from our clinic. So they're upstairs, we're downstairs, and we are on the phone nonstop. And as I mentioned before, we do have that collaboration with the St. Louis County Health Department to make sure any person who wants long-acting injectable PrEP comes and gets it from our clinic. And is able to do so, as well as if there's any issue with respect to laboratory costs that can be covered, especially if they keep receiving horrible bills, that we can cover as much as possible of their laboratory cost through our local health department, where testing is for free. As of 2022, only in the year 2022, we had 230 PrEP patients. 94.5% were assigned male at birth, 5.5% assigned female at birth, 4.3% are transgender or non-binary, 58.2% are white, 24.8% are Black, and then around 10 to 15% are Hispanic, Latinx, and Asian. And then you can see the age distribution here, with the majority of individuals being aged between 27 to 54 years of age. This is for all formulations of PrEP. This is not just long-acting injectable PrEP. These are our top 5 insurers, in other words, who I call my top 5 troublemakers with respect to PrEP and getting PrEP paid for within our clinic in Missouri. So as for long-acting injectable PrEP, we have 16 patients currently on Apretude. We have 8 patients who are interested, but cannot receive it as it is not covered under the pharmacy benefit, as their insurer requires use of a mail order pharmacy, and that goes against our brown bagging policy at WashU. And so we can't bring, our patients cannot bring a medication from outside of our clinic into our clinic to be injected into our clinic. It is against our clinic policy to do so. And so Caremark, CVS Caremark seems to be our biggest issue with respect to this, because if you are insured by CVS Caremark, they require that the mail pharmacy be their pharmacy. However, you get that mailed, who's going to inject it? And so that seems to be a major issue with respect to at least 8% of our patients who are interested. Other issues are insurance forcing Apretude under medical benefit, which cannot be billed by our pharmacy. There's pharmacy benefit, there's medical benefit. And unfortunately, if it's under medical benefit, then it cannot be billed and not be provided under the care of our pharmacy. Prior authorization has been required for most of our prescription, and if they're uninsured, it actually gets covered most easily. So the good point is that our uninsured population can easily get access to long-acting injectable PrEP. The hardest part is getting their laboratory tests covered for, including the fact that we just got Missouri Medicaid expansion. And we want to make sure that that HIV-1 RNA testing is obtained by individuals. So let's talk a little bit about equity, and let's talk a little bit about retention. Within our PrEP clinic, we have instituted a policy of zero cost. That means zero copay, zero cost. We want our patients to pay nothing. That is our goal. And so we tell our patients, if they receive a bill, if they receive a copay, if they receive anything, they need to let us know and speak with our PrEP coordinator and our PrEP navigator. We also have a great relationship with our specialty pharmacy in order to make sure that we have open communication with them. They are currently the ones who house our registry of persons who are on injectable PrEP and collaborate with our PrEP coordination and navigation team. We do use our 340B funds. We are a 340B STI clinic, and we use our 340B funds as well as a charitable PrEP fund as a secondary payer if individuals do receive a bill. And then we will do an investigation into what the cause of that billing issue is. We need to find the right coding combination. I call it billing code bingo. It's very annoying, but hopefully with the intervention of an ICD-10 code for PrEP, which is soon to be coming, apparently, then this will help with issues. And then, of course, making sure that we have an up-to-date PrEP registry, which we are just now instituting to give us information on injectable PrEP and to create a closed track of who's being seen when, as well as our collaboration with the county health department. The reason why I put these under equity is because we want to make sure that regardless of an individual's ability to pay, that they are able to get access to these medications. We serve a large, predominantly Black community, and we want to make sure especially Black cisgender women have access to any formulation of PrEP that they want to be on. We know that we don't have data on Descovy, and that's not an option for them. And many of them are concerned about kidney disease and developing kidney disease on Truvada. And so injectable cabotegravir is a great option for them if that is what they so desire. And it is our goal to make sure that they can get, so whether it is using our 340B funds, whether it is trying to make sure that the billing is correct, whether it is collaborating with our local health department for everything other than that HIV-1 RNA test, which we will eat the cost of. As for retention, again, our in-house pharmacy houses the registry, and they're the ones who actually try to make sure that individuals come in regularly for their injection. Every other visit, so the first 2 visits, of course, are going to be full clinic visits, and then every other visit after that alternates between a clinic visit and an injection visit. For those injection visits, those are the ones that we have standing orders set in order for them to get their HIV screen, and then their full clinic visit, they will do a full bacterial STI screen. Our in-house pharmacy collaborates with our staff nurses and our PrEP coordinator to make sure individuals get in on time, and we make multiple phone calls if they are nearing that deadline for that 2-week time period for which they can get their injection. And we know the due dates of each injection as well. We want to get individuals within that 2-week time period. Of course, we don't want them to miss. However, if they do miss, we have the option of switching them over to oral PrEP, and we coordinate with our PrEP navigator and coordinator to make sure that they have oral PrEP on hand so that they can switch over if they are unable to come. We also do reload if people miss, are far outside of the window of them getting that injection. And again, having that PrEP registry available on Epic is going to make our lives a lot easier. And so that is what we are utilizing, especially to make sure that we retain individuals into care. And that is it for me.
Great. Wonderful. Thank you so much. All right. Next up are our new friends from Southern Nevada Health District. We are happy to have Karen Dinda, who is the CHN supervisor, Zulieta Todd, who is a physician's assistant, and Mario Marcos, who is the PrEP navigator. And I believe, Glenn, you're going to share their slides.
Hello, I'm Karen. I'm the supervisor of the Southern Nevada Health District Sexual Health Clinic. So I just wanted to talk a little bit about our PrEP history. You can go to the next slide. I'll give you some of the metrics for our injectable PrEP program. We'll let you know about some of our retention efforts, and we'll talk about some of the lessons that we've learned in the progress. So we started our PrEP program in May of 2017, and then we began our injectable PrEP program in June. Actually, it should be June of 2022. Sorry, that's a typo there. I'll have to fix that one. But we gave our first PrEP injection back in June last year. We can go to the next slide. So we have had a total of 169 applications that were started. We've had 152 out of those were approved. 117 patients received at least their first injection. Right now we have 93 continuing on the cabotegravir. 54 people in total have discontinued from those original, or the total of the 169, and we still have 13 in process right now. So some have not received their first injection, even though they're considered one of our active cases. Next slide. So out of the people that received at least one injection, some of those people had to discontinue. We had some patients that moved, some patients had side effects that they had to stop the medication, and then there were a few that were lost to follow-up. Of the people that we started an application and then they never even received their first injection, one of the persons converted to HIV positive before we could start. There was high co-pays, so the patients decided not to pursue it. There were some applications that were rejected, and then some patients actually declined once we had the medication approved. And then the non-compliant, I should have had a better word for that, but we couldn't get them to complete the application. They weren't responding to calls, or we got the medication arrived and then we couldn't get a hold of them to follow through with scheduling. So that was a few of the cases there. The next slide, the next two slides are just who are the people that have remained in care, looking at their demographics. And it was just interesting to note that when we compared that with the next slide of the people that discontinued after starting at least one, if you look on the next slide, the slides look very similar for the most part. So we didn't find a lot of disparities between who started and chose to stop for one reason or another, and any of those. So some of the retention efforts that we have put into place here, you can go to the next slide, that we continually work on our process here, process improvement, staff engagement, talking about the program with staff, what updates, what reminders do we need to do. We do have automatic reminders, appointment reminders that go out from our electronic health record. We do also, in addition to that, do personal telephone call or text reminders for patient appointments. And then we do follow up on phone calls for missed visits. If they don't respond after 3 attempts with phone calls or texting, then we will follow up with some type of written letter correspondence. We do always schedule their appointment before they leave and give them an appointment card at their visit. So out of that total of 54 that decided not to continue for one reason or another, or never started in the first place, 35 out of those people are still in care on oral PrEP. So, and then I think Zulietta was going to talk about a specific case that we had, just to give some ideas of some of the issues that we've had with the program.
Yeah, so I just wanted to share like one of the experiences about a challenging case per se. So as more and more clinics are kind of starting to offer injectable PrEP, what we've noticed is I had a patient that decided to switch care to us, and he doesn't have insurance when he was at the other clinic, but then all of a sudden now he has insurance. He's due for his next injection in like the next 2 weeks. And then he came here and he wanted to kind of continue his care here with us. And now he has insurance. So we had to kind of try and get records from the other clinic, try and, fill out a prior authorization with the insurance. So we had to kind of transition him back to oral PrEP for the time being. And we did actually get a denial from the insurance, surprisingly. So we're kind of working on that, trying to appeal it, and hopefully he can back on the injection. Because the reason why he switched in the first place was because he wasn't he wasn't very adherent to the oral PrEP as much as he should have been. And this was kind of the better option. So we're going to try and hopefully we can get that approved for him, because we would hate to see that be an unfortunate missed event. So I just wanted to kind of mention that, because we really, I mean, because we were one of the first ones here in Vegas that kind of started this. So it's going to get a little bit more complicated now as more and more kind of patients and clinics start to offer. So that would be kind of a challenge to try and figure out how to improve the process and make it better for the patients. That way they don't have to discontinue their care.
Thank you, Zulieta. Yeah, that is one of the challenges that we've been hearing about, is people who are interested, and then if they're insured, they are coming up against some barriers. And Karen, you outlined some of that in your presentation as well. So I think we can follow up on that in our Q&A portion. I wanted to point out, Joseph, Jillian had a question for you in the chat. I also wanted to acknowledge Shauna's question in the chat. If anybody feels like responding to those in chat, go for it. We'll also follow up in the Q&A session. All right, to wrap up the presentation portion of this meeting, we have our three friends from the Care Center Dignity Health St. Mary Medical Center in Long Beach. Dr. Paul Lovely is the executive director. Christine Gonzalez is a nurse practitioner, and Ben Lomelli is the PrEP navigator.
Hey, everyone. Good to be here. And thank you all for sharing about your programs, and very interesting, and good to see so many people out there doing this work. And what I'm gonna do is just run through a few slides give you some numbers, and then I'm gonna turn it over to Ben to talk a little bit more about our successes and challenges, and how things are going kind of operationally. Care Center, we've been here in the community since 1986. We serve over 2,000 clients, so we're a pretty big HIV services organization. We have a medical clinic that does HIV specialty care. We're also rapid ART site, so we are able to get people started on rapid ART. We offer PrEP, PEP, STD screening and treatment. We're a PrEP Center of Excellence in LA County. We have a dental clinic, and then a number of support services as well. So we're kind of a one-stop shop, and take care of a lot of folks. Just a couple of other numbers. So we have about a little over 2,000 clients. About almost 1,400 of those are HIV positive, a smaller number of STI clients. PrEP, we have about 286. PEP, we do in 2022, we did PEP for 86 people. We also have our ED in the hospital also does PEP as well. So there's always a place on weekends and after hours to get PEP if people need it. And we also do routine HIV testing in our ER, or our emergency department. Viral suppression, retention overall is good. And right now we have 46 active Apretude patients. And we've been growing kind of slowly but surely, and then this is just how many injections we've been giving, per month, and then this is just a little breakdown of payers of insurance, or things that pay for their PrEP or Apretude commercial plans. And you can see there, with our regular PrEP patients, we have quite a number. About a third of our patients have a commercial plan, but much smaller with Apretude, and that reflects what everyone knows. It actually is. It's a lot harder to get approved on a commercial plan, so that is a barrier for our folks who are privately insured. Medicare, about the same. Medi-Cal managed care. So Medi-Cal is Medicaid in California, and we have about 25% of our PrEP patients, but you can see a higher number with with Apretude, and Medi-Cal actually is very easy to get folks on Apretude, which is great. And then these are and then about the same amount of PrEP app, the PrEP assistance program in California, about 40% for both of those. And then this just gives a little overview of some demographic things with race, ethnicity, and then ages with between PrEP and Apretude, not any major differences age-wise, and folks who are getting PrEP, oral PrEP versus Apretude, maybe a little bit different in this kind of 37 to 42 age group, but by and large pretty similar. And in these just gender, sexual orientation, don't really see too many big differences between our oral and injectable PrEP in these. And so that's the numbers. And so turn over to Ben and Christine to talk a little bit more about how things are going.
Thank you, Paul. Hi, everyone. My name is Ben. I'm the PrEP navigator here at the Care Clinic. So yeah, I'm going to briefly talk about some of our strengths and challenges, specifically from my experience as a PrEP navigator and what it's been like for me. So I'll go ahead and start with some of the strengths or successes. So we are in a unique position in that we have a specialty pharmacy that's co-located within the medical clinic here that processes all of our Medi-Cal patients. So it's licensed as a specialty pharmacy that allows us to pick up any Medi-Cal, any prescription for a patient who has Medi-Cal. We're able to walk over and pick up that prescription same day. So it's very convenient in that sense. Christine and I work closely together when it comes to increasing patient awareness around injectable PrEP. So with each patient, we discuss injectable PrEP, we give them information about it, and we offer it as an option to the patient. It's not necessarily something we're forcing upon, but more so discussing it as an option for them to see if it works best. And then, of course, we let them know that depending on their insurance, how long it'll take or what's involved in that process. We also have a LabCorp on site. So this is more so for patients who are enrolled into our PrEP app program. They can get their lab work done here in the clinic, and they don't have to go to like a Quest or any other sort of lab that's not located here, which is very convenient for them. We have strong support from both clinic RNs and medical assistants who actually administer the injection. So that's pretty unique because then it allows, Christine to have more time to meet with other patients who are here. If we are having a busy day, the medical assistants are the ones who can administer the injection. So that's pretty awesome. And then, of course, we are a PrEP Center of Excellence. So I'm a certified enrollment worker, and I enroll patients into the PrEP app program if they don't have insurance or they are uninsured or underinsured. Some of the challenges, we don't do buy and bill. So we are only acquiring the medication under pharmacy benefit, which, as you've heard from several other presenters here, that can be a challenge depending on the insurance plan. So depending on if they require a prior authorization or any of that, it can be very time consuming. A challenge that goes hand in hand with that is, insurances and the delay in actually receiving the medication based off what the insurance company is asking for. Another piece is the logistics of using these specialty pharmacies to ship the medication to the clinic. So ensuring that the medication does arrive on time for the patient's appointment. And I think someone mentioned earlier, they have an Excel spreadsheet. I also use a spreadsheet to help keep track of when patients are due for their next injection, what pharmacy we're getting the medication from, if it's been ordered. So I take care of coordinating all of the shipment of the prescription and making sure that it does get here on time. It usually doesn't take a while. The pharmacies that we're working with are pretty good at sending the prescription within 2 days. So it's pretty helpful in that sense. And then, of course, we have had some patients discontinue in the injectable The most common reason being, site soreness, just something that they can't necessarily tolerate. Other patients who have discontinued have been insurance changes or just lost to follow-up, but the most common being the sort of injection site soreness for some patients. And then an additional challenge is insurance contract limitations. So depending on the patient's insurance plan, whether it's a managed healthcare plan like Medi-Cal, we have to make sure that their medical group is one that we're contracted with to be able to see them. If it's not, I offer assistance in changing that sort of medical group so that we can see them. But usually the way that works is the new medical group, that new insurance plan won't go into effect until the first of the following month, which then delays care. So there's that aspect. And the last challenge is staff support. So I'm only one PrEP navigator who is coordinating the shipment of the prescriptions, who is sometimes submitting those prior authorizations and working with ViiV and submitting all of those enrollment forms. So on top of the navigation that I'm doing for the oral medication and what's requested of me by the county. So it definitely is, it can be a lot of work. And so, yeah, so that's all I have to share. I don't know if Christine would like to share anything.
I think, let's see, I think you summarized everything really well. And then if anyone does have any questions, I mean, we're certainly available to answer any questions.
Wonderful. Thank you so much. So this ends the presentation by the 5 different clinics. Dr. Lovely, would you mind stopping sharing? So I invite everyone to come off mic, raise your hand, and or type a question or comment into chat. And while people are formulating their questions, I had a couple. One, for those clinics where you've had people go back and forth between injectable and oral for whatever reason, when they go to oral, are you putting them on TDF FTC, or are you putting them on oral cabotegravir?
I'm putting them on either Descovy or Truvada, depending on what their insurance will cover. If it covers Descovy, they get Descovy. If it only covers Truvada, that's what they get.
Yes, I do the Descovy or Truvada on the insurance, just because to get the cabotegravir, you have to get it from Theracom, and that's a little bit of like a little process, like going to the pharmacy, like right next to your house. It's like it's a longer delay to get the cabotegravir from Theracom than to get from the pharmacy.
I will say here, the majority of our patients are covered for TDF FTC, but if they qualify for Descovy and were on Descovy previously, we just switch them back to what they were on prior to. But the majority of our individuals get approval, or TDF FTC as generic would be the easiest option.
And we have placed an emphasis on sort of like as a harm reduction approach, just initiating everyone on Truvada or Descovy or generic Truvada, regardless of if they say I'm interested in injectable. We kind of are interested more in that rapid start piece, and then we'll work to get someone on injectable if that's their choice.
Karen, Zulieta,
Yeah, so we do the same. So when somebody's interested in PrEP, they're a new patient to our clinic, we try to get them on oral PrEP that day. And then if they're interested in the injectable, we have them fill out the application, talk to them about it, and then get that process going as well. But same thing, if the insurance approves Descovy, we go with the Descovy. If it approves Truvada, we start with the Truvada, and then we try to get them approved for the Apretude as well.
And we have had patients have to bridge with the cabotegravir. Mariel's had more involvement with that because she does our processing of applications, so she can tell you a little bit.
We had a patient that was going overseas for about 3 months or perhaps,
So provider requested the auto bridge cabotegravir. So we requested it to Terracom. They do, it's free of charge from the manufacturer. There's no problem. You can overnight it. That was 2022, beginning of 2023, if nothing has changed. So that wasn't an issue. We were able to get all the doses that he needed for the time being, because provider did not decided to use Truvada or Descovy. So he continued on the PrEP injectable. We found no difficult from that pharmacy to deliver in a quick and timely manner to start the patient in oral lead if that is what the provider would like.
Thank you. So Michelle, I see that you're here and I'm going to put you on the spot. If you don't want to be put on the spot, say don't put me on the spot and get mad at me. But I wanted to clarify, I wanted you maybe to speak about the availability of oral cabotegravir so that you could get it right for us rather than me potentially getting it wrong. Maybe she's not here. Okay. Michelle is from Michelle Porter is from ViiV, and so if you happen to hear this and want to come on. So my understanding is that first of all, oral cabotegravir is not approved for long-acting PrEP. It is approved as a bridge, I think, for up to 3 months, I believe. Am I correct in that? But I believe that ViiV will provide oral cabotegravir without cost, regardless of whether the person is insured or uninsured. Jillian, I think you mentioned the difficulty of getting the medication, even if it would be free.
It's just the routing from ViiV, then from ViiV to Terracom is that versus like I don't think you can e-prescribe to Terracom directly. For the cabotegravir. So that's kind of like what I was alluding to versus like, like the Descovy, like, you send it to your pharmacy next door and pick it up. But I mean, it's possible, but you have to send it to ViiV, call ViiV, follow up, get ViiV to send to the patient. I remember like the first person that I had to start on it had oral lead-in. It took like a little bit for them to route that to Terracom. And that was last year. I don't know if it's changed, this year, because I haven't had anyone to start on the oral.
So it sounds like something that might be, oh, I'm sorry.
Yeah, I'll add this. I have had 2 patients who were going to be, they knew they were going to be out of the area for their injection. And I ordered it from Theracom in advance. So they took it with them on their, whether it was a vacation or in one case, a flight attendant who was going to be gone for a little while. And they are very, I did add it to our EMR, the Theracom. So, if I send it, I just send it by EMR and it hasn't been a problem.
Oh, okay.
Great.
Yeah, and it's true though. I mean, they mail it to the patients. I mean, there's a couple of days, they can't tell you the day, that they're on a flight or something. But, yeah, they've told me in advance and I have mailed it to them and it was fine.
Michelle, I see you came off camera, so you didn't mind I put you on the spot.
It's okay. I was just trying. I heard you anyway. So Theracom, we cannot order oral cabotegravir for just order it. It only comes through Theracom, and it's only for 2 months. And it's only when it's a missed dose or a planned missed dose or the oral lead-in, and it all has to come through Theracom. There's no other way to kind of get it. And I'm sorry that they had a long time getting it. Hopefully that's gotten better than it was a year ago. But that's all. Was there anything else, Robert? I heard you ask that question.
Well, I just wanted to be sure that I had that accurately. So then I'll put on my activist hat, or my activist toupee in my case, and say that it might be helpful to clinics if they could have a certain stock of oral cabotegravir on the shelf so that if they're, for whatever reasons, they need to give it to a patient, they don't have to go through an extra process. You're on mute, Michelle.
Sorry, Robert. As you get a new patient, you always have that option to do the oral lead-in. So yes, the way you're talking, I can't make that suggestion, but yes, you can get oral lead-in for any new patient.
Okay, so it sounds like what I can say is that you could order the oral lead-in for a patient and then have that stock of oral cabotegravir on the shelf. Now, that gets into a slightly possible complication that if the bottle or the box has one patient's name on it, and you want to use it for another patient, that's another story. Just as an aside, I'll say that another issue we're working on is the question of unused doses of Apretude that are unexpired. And we've been having conversations with ViiV as well as some other pharmacists, and we'll be ready to make some kind of an update on that soon. Does anybody else have any thing they want to add or any questions about going the oral lead-in or going back and forth between oral and injectable? I wonder.
I did have one question.
Yeah. Mm-hmm.
For, I guess, the clinicians that are here. Is there any reason to do oral cab over Descovy or Truvada or generic Truvada when somebody needs a bridge?
Nope.
Okay.
We don't even use the oral lead-in, to be completely honest. We just use the oral, whatever's available, just because we know that that can continue afterwards in case it is prolonged. So we don't even use the oral lead-in, but there is no benefit of one over the other.
Okay, that's what I thought too. We don't use the oral lead-in, and I in the package insert, I kind of thought it was more for people who might have an allergy to kind of test, but thank you.
Great. So I wonder if one of you would be willing to quickly explain buy and bill for people in the room who don't know what that is.
Well, we don't do it, so I won't say anything about it.
So buy and bill is you acquire the medication directly from a wholesaler, and you bill it as a bundle for the injectable, and also doing the injection to the insurance, and the insurance will reimburse you to the clinic directly. So that's the buy and bill process.
And am I correct in saying that you'd have to have the resources to be able to upfront buy a certain amount of Apretude before you could get this buy and bill program rolling along?
Yes, you would have to be able to pay for medication first. Also, so that also requires to know that the insurance will reimburse the medication. So we do have like insurance staff that does that before it comes in, because otherwise we order it, like it just sits there and like it can be onto the patient. So you have to like have all that in process and know ahead of time that the insurance will pay for it before you can even like start that. But like I wouldn't say to buy like a lot of Apretude. I would say just buy as you need it, just because like you don't want to overstock and like, like it just it expires. So that would like just buy as you go is probably the best way to do that.
Mm-hmm.
And we don't do the buy and bill process here either. And one of the reasons for that is you may get reimbursed, but you may pay $3,500, but only get reimbursed $200 or something, depending on what the insurance is willing to pay. So we have just gone the route of the patients will have to get it through whatever pharmacy they're insurance is willing to provide it through. And if it's a medical benefit, we've had to, I think, redirect a patient maybe to get it through certain pharmacies. Those pharmacies can deliver right to the clinic on behalf of the patient, and then we keep it here until the patient comes, but we will not purchase it for them and supply it as a medical benefit through the clinic.
Our field representative from VIV has been instrumental to help us a lot. And that's where every clinic that has some of the questions, you know, on buy and bill and all that. Field reimbursement from VIV will find that specialty pharmacy or specialty treatment location near you. They could potentially take the risk of buy and bill for your clinic. They will process and they will do the PAs or maybe assist you in some manner and then deliver to you the medications. We try to keep it a minimal. Most of our benefits are medical benefits, and then we provide the other ones for people without insurance. They're free of charge, free of cost through Walgreens, and they have no problem with, you know, providing that medication. So that's how we are able to grow in that amount within a year. So please tap to your resources from VIV, because they will do the footwork for you and find that local that will deliver to you clinic with ease, and bypass those certain patients that are not going to be approved through the normal ways, only through buy and bill.
Mhm. So thank you for saying that, because I do want to give a big round of applause to the VIV field reimbursement managers. We're not here to promote a corporate pharmaceutical company, but I am very aware of the fact that they have really worked tirelessly on the behalf of clinics to provide access and to streamline access to Apretude for many patients.
Yeah, definitely. Much harder than any other rep I've seen work.
There, so Michelle, take that back and give them raises. All right, so I wanted to get into our talk about equity and equitable access to PrEP, all PrEP really, but specifically to the question of whether injectable PrEP is going to help us improve access to PrEP for those folks that we have not been able to reach as easily so far. And so I think the first question I'd like to just go around to the panelists and ask is, how do you define equity or equitable access in your particular community or jurisdiction? And why don't we go in the same order as we did? Jillian, do you mind starting?
So for us, it is being able to open it to anybody regardless of insurance status, race, gender, as well as being able to meet the insurance requirements. So for example, I believe as of like 2023, a lot of Aetna plans like switched to buy and bill. So we had patients that were getting from pharmacies like in 2022. So because of that, we had to discontinue them because of that. So we're trying to like fit the mold for all insurance plans that we are able to accept anybody, whether it's buy and bill, like medical benefit billing, pharmacy billing, or uninsured billing.
Thank you. Caroline?
Sure. So I would say the first piece of equity for injectable PrEP for us would be awareness, universal education and awareness of PrEP. I think that's something that was lacking for oral PrEP in a lot of among a lot of key populations. Equity also means sort of minimizing financial barriers, insurance barriers to PrEP. We do that with oral PrEP really well, and we just need to figure out our workflows to make that possible with injectable PrEP. We aren't a clinic that bills at all, so that already positions us really, really well to sort of see patients who don't have, are uninsured or underinsured. And we also are in the position to have LabCorp cover for that expensive HIV RNA test, which is another perk, and really lets us be, a clinic that can help people who need access. The other thing I just wanted to talk about a little bit was the clinical experience. So I think that in addition to sort of universal education, there's also a way where we need to kind of work on standardizing that everyone who comes into our clinic has the same level of care. And that means like, we follow up with them about missed appointments. We proactively reach out to remind. A lot of those things aren't automated for us yet because of our electronic medical records. But it also means things like I was talking about with like trans inclusive and friendly sort of patient experience. I mean, our form should reflect the values of our clinic, and equity is one of those values. So yeah.
Thank you so much for that. Joseph.
Awesome. So I'm just going to piggyback off of what has just been said, because there's been excellent points shared thus far. For me, equity is patient-centered care, whatever that means for each patient. And so I want to make sure each patient has access to whatever PrEP modality that they qualify for or want, if that was within their sexual health goals. And that's going to be what we aim for. I refuse to gatekeep. I will not do an adherence assessment or seeing it, if they say they're non-compliant, why were they non-compliant? Was it difficult for them to come in? Was it hard for them to get transportation? How can we make our services work for our patients? That's equity, right? We should not put the onus on the patient all the time. The onus should be on us as healthcare systems to reach out to historically neglected populations and communities. The fact of the matter is that we in the HIV prevention field have failed trans and gender diverse folks as well as cisgender women. We have neglected them for years. They have not been a part of our models, and they have not been in our advertisements. They haven't been in our information. They haven't been in our pamphlets. And now we're slowly starting to make progress. An injectable cabotegravir is very lucky for us. It is available for all sexually active adults. So how can we make sure that it is available for all sexually active adults, but affordable for all sexually active adults as well? That's what we're talking about with respect to equity. So making sure that every person is assessed with respect to their interest in starting PrEP. Every person is aware of all of the different formulations of PrEP that are available. If they are in the local health department, if they are in my academic clinic, I will treat them all the same and try to make our systems work for us, because the system is stacked against us at this point. I'm in the Midwest here. I am in Missouri. We are dead last in terms of public health spending. We do not have the luxury of many of these other places. We just got Medicaid expansion, and our legislature literally just tried to make sure that they took it to the Supreme Court to prevent it from being enacted. Like, I'm not joking when I say we have disparities here, but the issue is that we have to make sure that we are working towards the systems that have historically neglected people. And not only that, you need community buy-in. I can sit here all day, preach to the choir here, but what does PrEP mean for the trans and gender diverse person? What does PrEP mean for cisgender women? What does PrEP mean for Black individuals, Hispanic, Latinx individuals, Asian individuals, people from different race, ethnicities, gender identities, all of that stuff? You need to figure out what messaging works for them, because it's not a one size fits all. And then making sure that when they're ready to come to the table, that we are fixing the system to make it work for them, not the other way around. And so that's how I view equity with respect to long-acting injectable.
Well, I think I would be glad to hear your preaching, as all of our preaching, even if we've heard it before, because it's a good sermon. All right, so Marielle, Julieta, and Karen.
Yeah, so I mean, everything that everybody has said so far, definitely. Like we're kind of lucky that we're at the health department here, so we get referrals from all of our community partners. Every patient that kind of comes through the clinic, there's a question on our intake form that asks, do you know about PrEP? And if not, do you want to talk about it? Our disease investigators talk to our patients about PrEP. The clinicians talk to our patients about PrEP. We have express testing for those who are just wanting to get tested. And they talk to them about PrEP. So, and we have also PrEP navigators that reach out to the community. I think they have their numbers, contact information at different sites that a lot of these patients follow, social media, stuff like that. And so we try. I know there's still a lot that we need to reach out to, but it's a process, and we try to talk about PrEP to everybody. And I think the injectable, yeah, definitely it's a good resource for, especially for women, and just in general, because of that. Yeah.
And I think I would just add that, and just reviewing our demographics and those slides that I shared with everybody, looking at who has the most risk of becoming HIV positive, considering Black males have the 1 in 2 chance lifetime of becoming HIV positive, and seeing the low numbers compared to the other, you know, I think that just looking at the number of females that we have on PrEP, like I think we have some opportunities for focused efforts on who do we want to reach out to.
Could I ask you, I've always wanted to ask about the, sort of the sex workers in, say, in Las Vegas, in Nevada, and what your sense is of how they access sexual health services, either from you or elsewhere, and whether they are receiving the same PrEP knowledge and access.
I can speak for here in the sexual health clinic that years ago, it wasn't necessarily, they weren't the first group thought of as offering PrEP to, but now definitely they would be offered PrEP, considered, definitely we would want to speak to them and offer that service if they came. We used to see a lot more of that population, I think, than we do currently in the clinic. So hopefully wherever they're getting, because they are required to have regular testing services, and that information gets provided to, they have to get a release to continue working for certain in the porn industry. I think that their leadership requires that of them. I know with the brothel workers, they have to have things reported to the government, the sheriff's departments in the communities. So they are required to come for regular testing. We're just not seeing as much of them here. Maybe Julieta can speak more to that.
I feel like before COVID, we had a lot more of the brothel workers coming in for clearance. Now, not so much. And I think it's because they have, there's other, I guess, clinics that are, because a lot of them are not technically in Vegas. They're like outside of Vegas, because as far as I know, I don't think it's legal technically in Las Vegas, in Clark County. But they do actually, some of them do travel from Northern Nevada to our clinic for that. I think a lot of it also is that there's also online PrEP providers. There's a handful of or not a handful, but a good chunk of patients that come in for maybe just an STD treat because they did screening with their online PrEP provider, and all of a sudden they have chlamydia or gonorrhea that needed to be treated, so they come in for that. But I think that that's a very good opportunity, and for those patients who can't, some of them are like, well, I just can't make it, you know, during your business hours. So it's a lot better for them to get it online because it's on their own time. They can do the testing whenever they're available, and they get their medication like in the mail. So I think that's a lot of the patients like that aspect, just the flexibility. So it's kind of like a mix.
Yeah. So it sounds like in this case, teleprep could be a big advantage, but injectable PrEP, there's still going to be some barriers there, right? So let me move on to Paul and Christine and Ben to go back to the original question of how do you define PrEP equity in your jurisdiction?
Just briefly ditto to what everybody else said. Absolutely agree. Meeting our patients where they're at, not tailoring we don't have a one size fits all kind of situation. We make sure we tailor our services depending on people's circumstances and do everything we can to make sure that they have access to the meds. But I guess for me, one thing is I feel like if we have patients who show up to our place or anybody's clinic who's on this call, they're going to be great. It's the ones who don't make it to our clinics that more worry me. And you know, and in LA County, it's a very big county, and a lot more people than ever have Medi-Cal, but it's very hard to navigate that system if they don't have help. And in our community, I feel like there's a lot of knowledge about PrEP, but among providers, I worry that there are still too many providers who are primary care providers who aren't comfortable prescribing PrEP or don't really talk to their patients properly about sexual health or know what to say to their LGBTQ patients. And those are the ones, you know, and, you know, because Medi-Cal is great at covering PrEP and, you know, few strings, but, you know, but it's, you know, but you have to have the doctor prescribe it, you know, first. So that's always been something I think that's really that we really need to improve equity.
Yeah,
Ben,
for
Christine,
me,
sorry, go ahead, Ben.
no, that's okay. I think for me, on thinking about it like on an individual level, micro level, it's knowing the community that you're serving. Here at Care Clinic, we see a majority Latinx population, and so having staff that reflects the community that you're working with. You know, I myself as a queer, like brown person who is bilingual, I can connect with those patients who are monolingual Spanish speaking, and make them feel safe in the clinic. So that's really important to have staff that is culturally competent, that reflects the community that you're serving. On a more structural level, and I don't have much experience when it comes to like grant writing or applying for programs, but I personally think that funding sources are really important. And I don't know if grant funding is the best way to sort of address all of these like structural issues. You know, we're expected to do a lot with very little. And most agencies who are doing similar work are competing for this money. And it's like, how are we going to end the HIV epidemic when the reality is the funding is just not ideal for all of it. So that's just sort of my own personal opinion.
Yeah, I agree with pretty much everything that everyone said. And I think the major point is in meeting people where they are, you know, whether they're working out of the area because, you know, they're undocumented and, you know, they come back and, you know, maybe they can only come back any 4 or 5 months, you know, okay, you know, we work with it. I've had people, I'll send the lab orders and they'll actually physically pay for the labs, send me the labs, and I'll keep them on PrEP. Okay, so that would be more PrEP, but I mean, I really do go out of my way to make sure that I do keep people on PrEP Aptitude's a little bit more of a problem just because of the fact that you have to be here. And like I said, I have had a couple people, one in particular, he was a flight attendant and said, hey, they've got me in, New York, and I'm here for a little while. So, sent him some pills, but, meeting people where they are in order to keep them safe.
Thank you.
As to getting more and more people, that's always been a challenge. We've been doing this for 7 years, and we've tried to attract different populations, and we have attracted different populations, but I won't say it's been highly successful.
Thank you, Christine, and thank you everybody for bringing up those points. It's always good to hear this. It's inspirational to remind us of what our jobs are and how we're really trying hard to do them in the best way that we can to serve our communities. I'm just right now pasting in a link. I don't know if some of you may know the website AIDS View. It collects HIV data from around the United States. And if they have on a county and a city, a jurisdiction-wide level, as well as a state level and so forth, one of the things that some of the counties have in that, if they have been able to get the data, is what they call a PrEP to need ratio. And what that is let's say, for example, we're looking at the HIV rates in 2021 in your county, and then we're looking at the PrEP use in 2022. And so we're seeing if our PrEP access is matching where HIV is occurring. In other words, are the people, the different groups of people or communities that are still getting HIV accessing PrEP also? And I think we know the answer to that, which is in general, no. And they come up with a number, and a number is not necessarily useful, of course, in program planning or something like that. But it does, if your county is on there, it does tell you how you're doing to get PrEP to people who might be most likely to acquire HIV in the near future. So we're getting to the end of our hour and a half. Thanks everybody for staying for the whole 90 minutes. I'll put out another call for questions, either in chat or raising your hand or coming off mute. I wanted to ask just quickly also to ad lib a little bit for a couple of minutes. To our panelists or to anybody in the room, would you feel comfortable at this point promoting your injectable PrEP program based on what you know your capacity is right now?
I would feel comfortable promoting it. I do have to speak with Ben because he did mention that he's definitely got a lot on his plate. That might be where we might slow down, is him being able, and it's a lot of phone calls. It's a lot of phone calls, a lot of follow-up and that sort of thing. So I understand, and so basically that has to do with the insurance companies, and just following up and that sort of thing.
Yeah. I mean, I think with oral PrEP, when I was in navigation, I used to see that one navigator could probably follow around 300 people on PrEP. Like when you think of the reminder calls, the follow-up, and helping with assistance programs. Ben, I saw that, I think when you, Paul, when you showed the statistics, you had 46 people on injectable PrEP. And so one navigator is stretched with 46 people on injectable PrEP compared to oral PrEP, where one navigator might be able to handle several times that many people.
I would say finding the same here in Las Vegas too. We have Mariel is pretty much full-time just following up on prior authorizations, medication reordering, patient visits, follow-up. It's a full-time job. So as far as stretching much further than we're at right now, it's challenging.
One thing I wanted to share that we, or I've started to try at in Baltimore is batch ordering. So we send, like we email our CVS in case, calling in refills was taking up a lot of time for individual patients. We email our CVS with everyone who's coming up in the next 30 days. And then, and that's actually a report that we pull from our medical record system about when their appointment is and when they're due and stuff. And so that I'm thinking that'll make it a lot easier. And I don't know if Michelle's still here from ViiV, but one thing I've been trying to work up the chain there is if we can get batch ordering for those people on patient assistance program, if we could somehow, email or do something in a concise way to get a lot of, people who are using ViiV for their medication to be sent all at once. That would save a lot of time. So far, we can't do that. I don't know if anyone else has had success with the ViiV Walgreens.
We haven't tried it, but now that you mention it, that would be great because they call about each individual patient. They want to know their birthday, their address, etc. They go through a whole thing and then they say, we're going to mail it out this day. Is that okay?
Yeah, it's so time consuming.
Right.
Yeah, we actually have been doing that. We started that pretty early on to at least, if not monthly, once a week or once every 2 weeks and Mary Alice has done an excellent job with getting her contacts in order with the pharmacies, but that has prevented some of that individual contact for each patient. She'll call with a list and sometimes they'll email her a whole list of patients that they need information coming up on. So that has helped in some, but it's still, at some point you're saturated with how many people you can keep track of with one person.
Yeah. Thank you, Karen. I'm going to, we have 1 minute left, so I'm going to wrap us up. Anybody who would like to be connected to either Michelle at ViiV or to your field reimbursement manager, please feel free to contact me and I'll provide the introduction. Jillian reminds us that ViiV offers a copay card of up to $7,500 for people with insurance to help with out-of-pocket costs for the medication. And then Nicole has typed a message in the chat to say that at their Walgreens specialty that they do reach out to the offices there. So my colleague Tamara, who I was so rude not to introduce at the beginning, my colleague from California Prevention Training Center, has put our next session registration into the chat. We're very excited for our 2 sessions in May. It's a 2-part series addressing PrEP disparities for all Black people, May 11th and May 18th. And our presenter is Leisha McKinley Beach, who's one of the most lovely people in the world, a favorite of ours. And she will be leading the discussions on those 2 days. So please applause for everybody who attended, applause for our panelists, and register for our next sessions. If you have ideas for things you'd like to hear from us or things you'd like us to expand on that we've already talked about, please email me or even put it in chat now if you'd like. Okay, we'll be open for another few seconds to accept all of your compliments in chat. And we'll say goodbye for now.